Bandung, and this is our new hospital outside Bandung. We call it Jatinangor. It takes 1 hour by car. Okay, next. I'm sorry. It's okay. I'm sorry for this technical problem. If you become a neurosurgeon, we're facing many technical problems. So you have to deal with that. Okay. Or I can just, next. Okay, maybe it's too long. My specialty in neurotrauma and skull-based oncology. I've been do some fellow in some of the very good center in the world. Now I'm moving to learn and practicing about cell therapy, immunotherapy, stem cell therapy, and engineered cell-based therapy. Okay, you see, it's very good view of your hospital and university hospital. In Indonesia, we have only 600 neurosurgeons. I asked Prof. Endo, you have 8,000, right? More and less. So you can compare it. For 3 million population, for one of us, we have to serve at least 5,000, which is impossible. Because if you see this archipelago, it's very wide. And it's have many small islands. Based on that, we have many problems. And we only have 8 training centers right now. Our government set a new regulation that not only government, university can open the residency program. We're moving to ask private sector, private hospital that have the resources to open new center. And in the red one, that's our center in Bandung, the 3rd old center in Indonesia. Okay. Oh, sorry. First services in neurosurgery happened in 1948 in Jakarta. At that time, we've been captured by Netherlands. So they help us to make the first services in Margaret Ziekenhuis in Jakarta. Then in the late 60s, early 70s, we established 3rd center, Jakarta, UI, Unair in Surabaya, and in Bandung, Unpad. It's short of Universitas Pajajaran. Now we have developed 6 divisions in each center, and we have more than 200 residents. In Bandung, we have 36. You can imagine, in one small center, we have 60, more than 60 residents. Okay, our university in Bandung, it's a name of Old Kingdom in Bandung. It was founded in 57, and it pioneering by our founding father, Iskarno, Professor Iskarno, one of the founding father of Indonesian neurosurgery. Okay, this is our university in Jatinangor. It's very wide area. It's a mountainery. And this is our hospital. I call it old because we have a new one. This is in Bandung. This is our center in Hasan Sadikin Hospital. Why? They have different name. Because at this time, this hospital belonged to the Ministry of Health, which I'm belong of Ministry of Education. So we merge. Okay? This is our founding father, Professor Iskarno, graduated from Bonn University at that time. This one is the first student. We call it Dr. Benny. Benny. Everyone knows Benny. He's very clever. And this second student, this is our first professor, Prof. Kahdar. And this is our conference room. At that time, we have a room that named after him. We call it Iskarno Room Conference. And every alumni will be put it in our wall. Now we have around 200 alumni. And we also put several people that become the department head or the professor. Okay? I'm the third one. So we continuing. This is our staff. This is all our staff. But since we established new hospital, which belong to Department of Education, then I have to move to new hospital and set up new facility over there. Okay, if you are a medical student, which is you have to finish it in 6 years in Indonesia, then you have to intern in hospital to practicing your knowledge. And after that, if you interested in neurosurgery, you have to go through 11 semesters. It means more or less 5.5 years. You will have this basic surgery rotation. You have basic neurosurgery rotation for improving your skill and knowledge. Then you have to have some division rotation. We have trauma. We have a lot of case of trauma. Skull-based oncology, functional, and infection. Because if you go to Indonesia, we still have a lot of tuberculosis cases that somehow it's become a meningitis in the brain, spine and peripheral, pediatrics and vascular. If you finish that, you have local exam and finally for final exam. Okay, this is how it's looked. It's very old building, but we manage in how they do their activity and share the cases every morning. We call it Iskarno Room, named after our founding father. This is the nuance when you have report, you have to go, you have to be in the podium and defending your case. Everyone will asking. And in the afternoon, from outpatient, from consultation from different department, we will discuss in the afternoon. In night shift, sometimes they also gathering to discuss the planning for tomorrow operation or for emergency operation. If they found different or difficult cases, they will set up a Zoom meeting with the consultant. And this system is developed when COVID happened. It's much more easier. We don't have to go at the same room, and the consultant just have to stay elsewhere. Okay. We also invite experts all around the world. So, Prof. Endo, Prof. Sasaki, you are free to come to our center and give motivation lecture for our student. We invite all of you come to Bandung. This is late Professor Juha give lecture and make some collaboration surgery in our center. This is some of visiting professor. This is Prof. Yoshida from Keio, and some of other cadaver or workshop in our center. Our tools, our surgery equipment is far beyond your equipment over here. But somehow we manage to give services in Indonesia. Even if you go to further hospital, we still use giggly, you know, like trepanation when you open the skull with your very good hand, okay? Not craniotomy. Like, I think it's been live, not using again in Japan for at least 30, 40 years ago. It's just, if you want to see those equipment, you have to go to the museum, then you will see that. Okay, but in Indonesia, we do our best to save lives. Okay, this is bedside teaching. We go to the ICU, we go to ward, and sometimes in the hospital, we don't have big screen like you have here to teach the student how to do the approach. But somehow that we did for the last 30 years. Okay, and finally, if you, at the end of your residency, you have to make some thesis. You pick the topic that you like, then we will do some exam. If you can publish it, even better. Okay. After that, we have local exam. And if they pass, then they will go to the board exam. Okay. We also push our resident. For morning report, we always use English. If they don't speak English, then we have to push them. Sometimes it's funny to hear they're not used to using English, but that's our system. So we push our resident to go to the international event, presenting their case and presenting their research. Sometimes they will win. Okay, it's become pride of the institution. And they also have their lives, sports, religion, things, and some of young consultant will join, not me, young consultant, young staff. Okay. Okay. And in 24, last year, we established our new hospital near our university, same area in Jatinangor. So it outside Bandung. Okay, we call it University Hospital, and I recruit 4 staff, young staff that will help me to develop the curriculum and services over there. This is young surgeon. I send it, so they will have their own specialty. Okay? But the main excellency over there is trauma center, because there's a many highway over there, and they can access very easy to our center. Okay, the first recruiter now learn about movement disorder surgery, epilepsy, Parkinson, lesioning, and it needs in-depth understanding of monitoring. I asked Professor Sasaki to help us to develop our monitoring system because it's very difficult and it's not covered by our insurance. So we want to develop that, and we will ask the government to support us. Dr. Adam Pribadi. Then we have Lazuardi, now been trained is neuropediatrics in other center. So they will come back and start our center with more energy. And this is Farhan, the youngest, and want to lead us in spine surgery. So I asked my mentor over here, Prof. Endo, to help set this Farhan mind, how to create the good services and the good academical environment in our new center in Jatinangor. Okay, we also have lectures over there because that the main campus, the main university. We also teach student, the young doctor, and we get a small amount of resident from Bandung. So we do the academical activity as well as clinical activity. We take all of our students to see the real patient and how we do informed consent. Of course, we ask the patient whether they want to become object to our student to observe or not. If they said no, then I will ask the student to leave. Okay, in our polyclinic, we start to attract many cases over there with neurology collaboration. And if we have patient in intensive care or post-operative, then they will come with us. We will ask many questions regarding what they learned from their studency in early of their activity in campus. Okay? And we have emergency. We will teach them to do the right thing, and we will show them in emergency situation like this in our center, because we have facing many ventilator attracted tracheostomy. Then we did our own tracheostomy. We are not consulting in anesthesiologist or in ENT. We did ourselves. Okay, and at large we collecting many cases. So in increasing many cases, we will ask more students to studying in our new center. And our resident will planning the approach, positioning, and after that we will guide them to do the surgery. But the main thing is how you learn before the surgery, how you're planning your work and after the surgery. Okay, what is the challenges? Not only in our center, but mostly in Indonesian perspective. Logistic, because we have many islands separated by water. It's very difficult when you have emergency patient outside the island, different island, is difficult. So we also teach surgeon, general surgeon, if there are some emergency cases, then they have to do as they teach in our center. We give them the knowledge in handling the specific emergency situation, like epidural. We allowed them to do some technique. We call it burhol, to save lives. Okay. Then after the emergency handle it, then they can wait for several times to send the patient to our center. Next is distribution. We only have 600, only 600. But if you see, mainly stay in Java Island, in Jakarta. Then in Bandung, in small island, it's very difficult. Not only because it's difficult to reach, but the facility. You cannot work as a neurosurgeon if you don't have CT scan in your hospital, right? So it's a challenge how to set up the good environment for our surgeon over there. It's difficult, but that's our problem, distribution. Jakarta is much more attracting because you can very rich over there comparing if you just go to the island, okay? Sad, but it's true. Okay, what is the future? Once my Professor Saito in Todai said, neurosurgeon will have a good advantages in technology and biology. Both will be a good supporting for our expertise. Okay, like AI, robotic, 3D printing. They will come soon. So we have to adapt. Long time ago, endovascular is not developing. You just have to open, you have to clip. Okay? But this day, you don't have to open anything. You go just like play games. Spine. Open surgery with endoscopic. Minimal invasive. In my place, patient is very scared when they give the option to open surgery. Okay? So we have to shift our paradigm about this approach. And cell therapy. If your scalpel, if your knife cannot reach or you cannot treat anymore, it's not operable. Do we still have option to treat our patient? Then this option can be wide range from immunotherapy, engineering cells, stem cells, or it's metabolite, secretome, whatsoever. Okay. So the editing gene is become one of future tools for that. Okay, so that's the end of my presentation. Hopefully it's not boring you because now this is a long day. You are very busy for today. So I ask every one of you to visit our center and hopefully we can share knowledge and experience and culture between Tohoku University here and Pajajaran University in Bandung. Thank you very much.
Thank you very much. Does anybody have questions? I just had a question about to get into the neurosurgery.
Yeah.
How difficult for the medical students to be a neurosurgeon?
Okay, I will give you some analogy. Our center comparing with another 7 center, usually we will receive submission of new resident around 18 or 20 applicants based on their experience and the good faith to join with our center. Then they have to do exam, written exam, and some interview. We only take 4 of them, and the rest will be rejected. But there's one rule in Indonesia. If you do 2 times application, you cannot do for the 3rd time. If they fail 2 times in my center, they cannot ask and submit for another center. So it's difficult. And based on that, we do some evaluation, Professor. We want to change it because that's all rules. We want to change it so they will have another option. And we will open another center, not from government, because government is already have some burden to open new center. We will ask the private sector, private hospital that have the resources to open new center in Indonesia, hospital-based residency, because the 8th center is university-based residency, just like the United States, Hopkins, Mayo Clinic, Cleveland, that's private sector, right? Not government. So there's some positive and negative, pro and cons, but we want to open that possibility to reach more students for become a neurosurgery.
Thank you. Thank you. Any question? Oh, please.
Thank you very much for your nice
Thank you very much,
presentation,
Professor.
Professor Fadi. May I ask about treatment for cerebral aneurysm?
Aneurysm. Okay.
So in Japan, it depends on institution, but now clipping versus coiling is almost 50-50.
Yeah.
Okay. What the ratio in your country and what will happen from now?
Okay, that's a very, very good question, Professor. We don't have the exact number, but it's shifting. We've been teach to conventional method clipping, but this day some center develop the endovascular. Sometimes we do both. In my center, most of our staff, we have 3 staff that have the license for vascular surgeon. Most of them been taught for open surgeon, for clipping. But since we have to follow the trend, then we also ask them to develop their capability doing endovascular. So in my center, we did it both. In Hasan Sadikin, mainly endovascular. But the government told every center, because endovascular facility is more difficult to set up, so they asked many centers to develop open surgery, clipping. So there's some proctorship for that, and one of our colleague over there been have a special task from government to set new center for vascular in many islands of Indonesia. It's shifting, but we don't have the exact number for that. So we call it hybrid. You can do both. You can open it, or you can do endovascular. If you can do endovascular, if something happened, the accident happened, there's bleeding, then you have to open that. You can do it both. Okay. Hi, Sensei.
Thank you. Any more? Yes, please.
Hello, my name is Fumito Sasaki, a fifth year medical student at this university.
Fifth year.
Yes.
Nice.
So nice to meet you.
Nice to meet you.
Today, Ahmad Farid, I truly appreciate your insightful lecture. Thank you so much. So I have one question. So now for the future in Indonesia, what advice would you usually give to medical students in Jatinangka and young doctors who aspire to become neurosurgeons, like surgical skills or research papers or learning languages and so on? Yes, what advice would you usually?
My advice.
Mhm.
Okay, actually it's curriculum.
Mhm.
It's written in the curriculum
Mhm.
that the student, they have to do all the comprehensive teaching over there. So we now we left the teaching method by give presentation. They have to learn at home. They have to discuss. They have to come to explain about their learning in their home with their friend. So we as a lecturer just sit down and see whether they know the comprehensive way or not. We call it's based on their knowledge and switch the role of explaining. They will explaining what they learned. Then after that, we will give some advice, or if they're misled what they've learned, then we have to correct it. And after that, we push them to take one or two projects for their final exam. For example, that you mentioned about publish some research project or make some meta-analysis regarding something that they're interesting. We push them not only learn, and they can tell everyone by publication what they learn in their home or in the lecture room. After that, then we ask them to come with us to see the patient. So they will applying what they learned, and sometimes it's difficult if you only read, but you don't know how to apply it in the patient. In bedside teaching, then we will guide them. And basically, after that, we tell if you want to become a neurosurgeon, you have to learn about neurology, because that's the basic of that. We teach you how to handle the patient, the surgery, it's a bonus. But the basic thing is about the neurology knowledge. Okay?
Yes, thank you. I
Okay,
think-
please come
yeah.
to Indonesia.
I think
Then
that-
I'll show you our new hospital and campus over there.
Mhm. I think those things are very important for me, for us. So I want to do that things at Dr. Endo's lessons. Thank you so much.
Yeah, thank you very much.
I had some questions from the Zoom.
Okay.
Okay, this is from Dr. Hirosawa. She's a graduate of the Tohoku Medical Pharmaceutical University.
Yeah.
And she says, I understand there are many remote islands.
Yeah.
Okay. If technology for performing remote controlled surgeries advances, would you consider actively introducing it? Remote control surgery.
Yeah, absolutely. But the main problem, even in that remote area, there's no electricity. You isolate it from Wi-Fi. So if our government can handle it, that the microenvironment for this advanced technology, I think that's the real solution, because they don't have to come to the main island. Some pioneering the drone to send vaccine to open the remote area. It's been challenging in that way. So if that time happen, we can develop remote or teleconference or robotic surgery far from the site. That aid center will develop it, because that's the main problem right now, Professor.
Okay, yeah, thank you. So another question, this is from the Reza. I just read it, okay? Knowing the situation and the reality of Indonesia is limited. You mean the limited resources?
Resources.
Yeah, both
Exactly.
professional and facility. Is there any solution or policy changes to improve both aspects? And what both Japan and Indonesia could do regarding the issue?
Yeah, so our government right now pushing to produce more neurosurgeon, that they will go to the remote area, the island. The government promising to build the basic need for imaging, for the operating theater, for neurosurgeon. That's the promise. Then sometimes the surgeon themselves have some hesitation to go there, because it's far and they don't know how to have some income, right? Because they don't have many options out there. Then the government also said, if they want to be put it in those area, the government will support them with some financial issue. So if that truly happen, then we can have some power to put the neurosurgeon far from the capital or in the main island. And what we can do for this collaboration, Japanese Indonesian collaboration, Japanese government do a lot for give some the scholarship, and even like Professor Endo accept my favor to send our staff over here. It's a very good help for us, because we have many center, but this day we want to upgrading into new fellowship program schema. So if Japanese neurosurgeon help our staff, our student, our neurosurgeon over here to become as good as they are, then that's a very big deal of some good collaboration. That's from my opinion, Professor.
Okay, thank you very much. Yeah. So any more questions? Okay, please. Do you have a mic? There.
Hi, I'm Will Skato. I also fifth year medical student here.
Okay, nice.
Thank you for your great presentation. And I learned a lot about the current status of medicine in Indonesia. And I have a question about the emergency system in your country.
Emergency system.
Yeah.
Okay.
In your presentation, you mentioned the difficulty of them since, Indonesia is an archipelago with many islands, right?
Yeah.
Yeah, so I'm curious how the emergency medical systems works there, and does each island
Yeah.
provide its own medical care, or is there any transporting system in the country?
Yeah, so it's very difficult actually. Even in the big city, even in Bandung, in Jakarta, we have problem in pre-hospital, how to bring the victim to the center. There's a road trafficking. Sometimes we cannot manage to bring the patient go through this traffic jam, even in Bandung. And we don't have national pre-hospital system like what you have here. The ambulance, how they control by center, and how they react to make some the emergency situation, for example. That's still problem, even in the big city. For the island, it's much more worse because even if they have some transportation boat, sometimes the sea is not friendly. You have to wait until some big wave, or for example, there's some tsunami, there's uh, some catastrophic. So it's very difficult. And what we did is we give some extra attention for the far area and the doctor that willing to stay over there, usually not neurosurgeon, but general surgeon. General surgeon is everywhere, right? Or even student, medical doctor that been trained to have some emergency treatment over there for stabilizing the critical event. And if they can stabilize it over there, then we hope the patient still have some time to send it to our center. So it's still homework for us. Pre-hospital is not working. For example, you have protocol over here. If there's something happen in the road, you have some critical time. In the United States or in Europe, they make a rule in few minutes, they have to come to the emergency, right? We don't have that. Our regulation not push those situation so we can save many lives. Still difficult. Sometimes in different area in Indonesia, in jungle, we try to develop medivac, medical evacuation, but it's costly. If you are have money, then you can use that service. If not, they just stay there and wish they can survive until they send it to our center. Okay, good question. We don't have the answer right now. Hopefully, government Indonesia will learn from good country like Japan to develop this pre-hospital system.
Okay, thank you.
Okay.
Anything? Okay. Yes.
I'm Seigo Tachikawa. I'm fifth grade
Fifth
of
grade.
medical student here. And thank you for presentation. I'm interested in anesthesia in neurosurgery. So I want to ask you about what is the benefit of for neurosurgeon to running anesthesia
Anesthesia. Okay.
anesthesia and perform it themselves. So what is the benefit of anesthesia themselves?
The benefit of anesthesia.
For neurosurgeon to sorry.
To work with anesthesia,
Yeah, yeah.
to learn.
Is it neurosurgeons do the anesthesia by themselves?
No. But we know the drugs, that's the basic knowledge, right? How we, for example, in increasing intracranial pressure, sometimes we have to give some drugs, right? Medication, even for sedation, for example. We know the basic knowledge. But in our center, we have close correlation, work together with anesthesiology. Because sometimes if the anesthesia is not do the neuroanesthesia, when you open it, it's the brain will swelling. So in our center, we have very good anesthesiologists, and even they have subdivision of neuroanesthesia. We close together and we work together for all many difficult cases in Indonesia.
Your question is the neurosurgeons do the anesthesia by themselves? Then I think the answer in Indonesia is, they are separate. But in Japan,
Yeah.
we still have some hospitals, neurosurgeons do the anesthesia by ourselves,
Oh,
especially weekend or in the nighttime. The patient come in, and then there is no anesthesia people
okay.
on call. So I have to do it. I mean, we have to do it by ourselves
Okay.
and do the operation, which still happens.
Oh,
Japan.
nice. So in that case, you do like setting all this ventilator machine by yourself in those area.
Actually, we have internal rotations.
Oh,
So all the students graduated, then they have spent how many months? 3 months in anesthesia or emergency department, okay? So
Okay.
they learn at least how to do it in anesthesias. So like my age, when I was like very young,
yeah.
I have seen the patient, then I do the angiogram by myself,
Okay.
then I do the intubation, I do the anesthesia,
Yeah.
then I do the operations.
Wow. Do you
That
have that,
happened.
Farhan? No? We don't have it, right? We can do intubation. We know the ventilator. But basically, we never did it by ourselves during those operations, Professor. I just know that. Wow.
So yeah, which actually you may want to ask questions to Indonesia, but this really happens in Miyagi Prefecture.
Oh, I see. I see. Okay, that's great. That's great.
Thank you.
Thank you.
So it means the government have to pay you twice, right?
Not really.
Not really.
Okay.
Thank you very much.
So I move on to the second topic. Just great that actually most of them is from the Indonesia, but I think 40 people is in the Zoom now. 47. Can you see? 47 people. So yeah, thank you very much for coming, and really appreciate it for the great discussions and the questions. So okay, I just move to my talk. Okay, can you see this okay? Thank you very much for coming again. And I would like to share neurosurgical training in USA, which I experienced, then maybe we have learned a lot about the difference between Japan and Indonesia. Now I can introduce a little bit of American training system. So, like I said, there is a meeting after this meeting in the cafeteria. So you may all welcome to join. And also after my talk, I would like to take group photos. So after my talk, just before leaving, just to come to the center here, then we are going to take pictures, okay? Okay. So today's topic, I would like to introduce myself, okay? Then this is really 20 years ago that I had a training, clinical training in USA, Mayo Clinic. Then at least I want to touch like 3 differences between Japan and USA. Then I touch upon the topic about collaboration with Indonesia, okay? Japan, Indonesia, unity may do something good. So introductions. So I have played soccer a lot. This is actually the when I was a 5th grade. Actually, in these pictures, there is Dr. Fujimori from neurology, and goalkeeper is Professor Tokunaga in the what's his area? Gynecology. Okay. So, anyways, so I was graduated from Tokyo University, but I spent 1 year as an exchange student in University of California. So that was when I was a 6th grade. So like now the 6th grade students studying a lot, okay? So they are taking exams. So when my classmates taking the exams, I was in California, then play golf. So I spent 7 years in the university. Then, you know, when I spent 1 year in California, I was really motivated to take exam for the United States medical license. So when I came back, I studied and passed the USMLE, which is the medical license examinations. There's several steps. I don't know the details, the current status, but at least I have passed the USMLE step 1. This is the basic medical exams. So step 2 is the clinical medical exams. So I passed it somehow. Then I graduated and started neurosurgical residency in Sendai. That was the 1999. Then 2 years after, I passed the clinical skill assessment. That's what we call OSCE. See the patient, asking the questions, taking the exams, then writing the chart, then present it. So this is what we call clinical skill assessment. You know, United States OSCE system. Then step 1, step 2, clinical skill assessment. Then I finally got the medical license. Okay. So then I had lucky enough to get the positions as a fellow, clinical fellow for 2 years. Then this was the 2003, 2005, which is postgraduate year 4 and 5. So I was the neurosurgical resident in Japan, but I spent 2 years in USA. So then after that, actually, I wanted to do the research for the spinal cord injury. So I spent 2 years in Sweden after that. Then I came back to Japan. Then I got a degree, PhD degree from Tokyo University. And I did interesting research in Sweden, great time. I didn't have time to touch it about it. But today, I focus more on the clinical fellowship in Mayo Clinic, okay? So this is Mayo Clinic. It is founded in 1919 by Mayo brothers. Then I think the philosophy is great. Actually, the needs of the patients come first. So the people working in Mayo Clinic is really nice. Everybody is nice to me, nice to patients, nice to each other. So I really felt great in Mayo Clinic, especially in Sendai. There's a lots of tough things, you know, lots of hard things. So, but I felt so calm and nice in USA. The Mayo Clinic is very famous, worldwide famous. Then they have a group practice model. Then people in USA vote which hospital is #1 in US. Then always Mayo Clinic somehow. It's in Minnesota, Rochester. It's very far from New York, very far from Los Angeles. It's in the Mid-East, Midwest. Then minus 20 degree in winter, not so much fun in the town, but somehow they like Mayo Clinic. So this is the Mayo Clinic Rochester at the time of 2003-04. So I have checked the facts in 2002. Okay, so this is a Rochester. Then the big building is, everything is related to Mayo Clinic. Those apartments is for those who work in Mayo Clinic. Those buildings, there's the 2 big hospitals, okay? St. Mary's Hospital and the Methodist hospitals. Then outpatient clinic is separate because there's a lots of patients coming all over the country and they want to stay in a hotel. So there's a lot of hotels for the patients. Then outpatient is different building. Then hospital bed, about 2,000, which is not so much bigger compared to like Tohoku University, University Hospital 1,000. We have 500. So USA hospital is very large, but hospital beds not so much. But take a look at the number of the residents who is in training for the many subjects, 1,900 residents. So how many residents we have? So that's a lot. Then operation rooms, including 2 hospitals, there's 100 operation rooms, 100. Then surgical procedures, 200 every day. Then how many MRIs they have in all those 3 hospitals? 200 MRI machines. Then they do 3,600 MRI, CT, radiology scans every day. So that's a lot. So this is neurosurgery. So actually the staff neurosurgeons, 10 neurosurgeons, okay? Then the residents, which is from the PGY postgraduate year 1 to 7, so residency program. In Japanese, this is probably the Koki Kenshui. They are 17. So it's about 30 neurosurgery members. So this is actually the picture of where you can find me. The center is a chairman, Professor P. Plus. The other members, they are all residents. So they look young, look not so young, but anyway, they are all residents. So we gather and we do the practice. Then we are making, from the 100 operation rooms, okay, neurosurgery department can use 7 operation rooms every day. How many operation rooms can we use? We can use operation rooms 1 in a few days. But anyway, so they have summed up the 3,400 surgical procedures every year. Then this is the case numbers of 2003, 20 years ago. So they have been building more, then the numbers is more right now. I haven't checked it for the recent, but anyways, you know, this is 10 times more than the Japanese regular neurosurgical hospitals. I don't know how much cases in Indonesia you do it, but. So residency program in USA. So there is a 7-year program. So first year, which is an internship, they got into the neurosurgery already. They are neurosurgery residents, but they do the neurology, trauma, and the general surgeries, okay? So they, you know, in Japan, we do the internship kind of. So this is a 2 years. They have been rotating many things. But in Japan, they have not yet got into the residency program. So we have 2 years internship in Japan after the students graduated. So, but in USA, there's an internship. So second year, they have more specialized for the neurosurgeries. Of course, neurosurgery, 7 years, okay? Then there's other areas, surgeries, 5 years, internal medicine, 4 years. So it depends. But neurosurgery, 7 years. So they have worked in clinic and the surgeries and the research. Then finally, 7th year, they went to the chief resident. So Maneho here is the Indonesian chief resident, right? So after in the chief resident, they more responsibility. So anyhow, so they graduated after that, okay? So the number of the residents is very much strictly determined. In Japan, let's say, I would like you to all to be a neurosurgeons, okay? You can be a neurosurgeon, you can be a neurosurgeon, you can be neurosurgeons. But in USA, it's not gonna happen. 1 resident per 1,000 surgical cases. So in Mayo Clinic, 3 residents every year. Let's say people wants to be a neurosurgeon, 5 applies, 10 applies, 30 people applies, but no, only 3. So there's only 150 spots for the neurosurgery residents. So if you want to be a neurosurgeon, only 0.15% of the medical students can get into it. So it's really kind of narrow door, I would say. So there is always a competitions. You want to be a neurosurgeon, you want to be a neurosurgeon, you want to be a neurosurgeon. But you have to prove that you are going to be a good neurosurgeon. So what are they going to do? Medical students, you know, this is the medical exam. We are going to have a medical exams, okay? So this is pass or fail only. You can pass 72%, you can pass 87%. There's no difference in Japan. But in USA, they are changing the rules, but at least before, and when I knew it, then a student must get better grades than the other students. Then say, okay, I'm better than the others. Okay. So there is always competitions. Shall we do something? I cannot mute the video. Lita, you will be okay. It's okay. Anyway, so let's move on. So there's always also the competitions. after graduations, after you graduated from the neurosurgery residency, okay? So for example, you belong to, let's say, Tokyo University. Okay, you graduated from the Tokyo University medical neurosurgical residency, okay? Then you still can belong to Tokyo University. You still can belong to Tokyo University. You still can belong to TMPU. But in USA, no, you have to graduate from the residency, you have to leave. So you have to find another positions for you. So there's also the competition to get good permanent positions. After the neurosurgery, you want to do the endovascular, you want to do the spine, you want to do the brain tumors. So there is always a fellowship positions which you want to apply. Then you have to be a member of the fellowship. So there's always competitions. So this is what I got, performance evaluation form. So every 3 months, all the residents got this form. Okay, you did do a great job, you did do okay job, you did do not great job. So every time, every 3 months, staff members evaluate residents. Actually, residents evaluate staff members also. So we evaluate each other, but this is going to be a pile of your evaluations. So you are going to have 6 years evaluation form, then you hand it in, say, okay, look at my grade. I always got A plus, A plus, A plus in Mayo Clinic. Then, okay, meaning you're good. So you go into the endovascular fellowship in New York, or you can go to the pediatric fellowship in Los Angeles. So it's always competitions. So you are constantly evaluated. So neurosurgery residents, even though they got into the residency program, they still have to get the better grades than the other residents. So always competitions. So this is the schedules, daily schedule. So wake up 4:30 a.m., okay, every day. Then there is going to be an AM round. You are kaishin, from 5 to 6:30. So we make rounds. We see the patients. They have been already wake up. Then we meet with the staff neurosurgeons, staff surgeons. Maybe I misspelled with the staff, but anyways. So we go to cafeteria. Actually, the residents can eat anything in cafeteria for free in USA. So people, hospital don't want you to get tired, okay? So residents can go to the cafeteria, eat, drink Coca-Cola, drink Sprite, drink coffee, everything is free, at least in Mayo Clinic. So operation starts at 7 a.m. What time we start operation? So it's really early, okay? So why can we make rounds at 5 a.m.? Because people in the hospital wakes up really early, okay? So blood tests, nurse take the blood at 4 a.m., okay? The blood tests available. This patient have a hemoglobin low, the CRP is higher than yesterday. So those things, results is available at 5 a.m. already. So when we make AM rounds, which is 5 a.m., all the data is available. So we can make a judgment. So we can see the patients at 5 a.m. Then there is a conference from 7 to 7:45 or 7:30, okay? The patient is already in the anesthesia. So they are waiting for the operations. But during that time, we have conference. Actually, I have never seen anybody sleeping in a conference in USA. Maybe because it's really competitive. Somebody is sleeping, then the professor say, okay, you're sleeping. You got the B grade, C grade. But anyhow, nobody was sleeping. That was really different from Japan, actually. Anyway, so operation starts. So it's already started. So after the conference, we move to the operation room. The patient is already intubated, anesthesia, ready to get positions. So we start the operations like 7:45. So even 9 hours operations, long time. It finishes at 4 p.m. Okay, because we start at 5 p.m. 5 a.m. So 12 hours is 5 p.m. So we have a PM round. Surgery is every day. Then we actually go to bed at 9, then wakes up at 4. So 7 hours sleep, which is really a good sort of life cycle. You go to bed early, you wake up early, you actually have a dinner with your family. You can even do something with your children. So neurosurgery residents is in operation room every day. So actually, there is a junior resident or a physical assistant. Then we also have a Keiko, that the nurse practitioner, helping us to see the patients. Here's the other one. So then we also have a lot of people who is working. So let's say, okay, we need an emergent CT scan, okay? We have to bring the patient to the CT. Do the doctors take the patients to the CT scan, move in bed? No. Do the nurse do it? No. There is escort service. So we call escort service. Then they come in, they bring the patients to the CT and bring them back. If the respiration was not good, saturations is lower, then we call respiratory specialists. So they come in, they take care of it. So we don't, like residents is in the operation room, then spend most of the time without any interruptions. So most of the cases, calls, necessity has been taken care of by the physical assistants. We don't, in Japan, we don't have physical assistants. This is different from the nurse practitioners. But anyways, there's a lot of people working in the hospitals. So one thing that we have to remember is when we see the patients, meaning, we do operation every day, okay? Then we have operation next day, okay? Monday we did operations. Then there's operation Tuesday, okay? Then at least on Monday night, I haven't seen the patient yet. I just see the patient chart on Monday night. Then Tuesday morning, the patient is already intubated. So I have never seen my patients before the surgery. I just see the patients intubated and ready to get positions. That's the first time that I see the patients. So I would say it's a little bit difficult to see in the bottom, but it's like a belt conveyor. Patients coming, do the operation, coming, do the operation, coming, do the operations. So it's really sort of the smooth, but kind of shallow and speedy rotation of the patients. So I would like to touch the three differences, USA and Japan, okay? So this is the subarachnoid hemorrhage, okay? So we have the patient, then we do the MRA, okay? There is aneurysms, so we do the clipping or we do the coiling, either way is fine. Then we have a post-operative care. There is a vasospasm from the 4 days to 14 days, so we have to take care of the patients. These things, like I mentioned, even in anesthesia, all done by neurosurgeons in Japan, okay? That's really usual things. I don't know what's happening in Indonesia, but in USA, first, stroke neurologists come in, okay? I said 10 neurosurgeons, okay, 10 staff neurosurgeons in hospital. How many neurologists do we have? 50. 50 neurologists in the hospital. In all the time, all over the USA, the number of the doctors is very coordinated and systematically organized. So 1 neurosurgeon and 5 neurologists. That's always happens. So there's a lot of neurologists. So they come in, they see the CT. You know, this hospital, same thing is happening. Neurologists, doctors is really good in taking care of the stroke patients. So they see the patients, checked it, CT, okay, this is the subarachnoid hemorrhage. So then we are going to ask the endovascular treatment, which is done by the neuroradiologist. But let's say we do clippings. So now neurosurgeons come in, then we do the clipping. We close it. Then next day, the patient is transferred to neurology department. So we only see the patients one day, at least in Mayo Clinic. Maybe it may be different in different place. But post-operative care, you know, we don't do it. We don't see the patients at all. So neurosurgeons only involved in operations. This is same as the brain tumors. We do the operations, brain tumors, but after the operations, radiation, chemotherapy, there is a radiation oncologist. There is a chemotherapy oncologist. So we refer the patients. So we don't see the patients at all. That's a little bit sad, I think. But anyways, the Japanese neurosurgeons involve the patient care from the beginning through the end, even after the surgery. So that's why I bring up these pictures all the time to the students' lectures. Difference between baseball in Japan and the baseball in the USA. So this is a very famous pitcher in Japan. He has done lots of work, you know, starting and pitching through to the 9th inning at the end. So this is he has pitched all through, then he has completed like 53 times. But in the USA, he only did it in 6 times. Because after he throwed until the 7th innings, then there's other people coming, waiting to work. So we change. So that's how the Major League Baseballs may be different. Maybe Japan is a little bit more, I don't know about the details of the baseball now, but the Japanese baseball is maybe changing. But it's really typical for this, you know, pitcher Tanaka. Then he has done lots of work from the start to the beginning. Then Japanese people actually like it. I see the patients in outpatient clinic, okay? Then I say, okay, let's do the operations. Then I do operations. Then after that, they want to see me. You know, they don't have any problems. They don't have anything bad, but they want to come to see me without any reasons. They just want to see me. So Japanese people like to be cared by the first surgeons or main surgeons. I would say, okay, you have to go to the other hospitals. Then they look sad. Oh, no, I want to see you until I die or something. But so that happens. Difference between Japan and USA. Pitcher in USA get more money. I think the same things in neurosurgeons. I don't want to talk much about it. So difference between US and Japan. Surgical case volumes, okay? We have been working very hard, okay? So, but USA, they have operations every day. So this is a comparison, my case. 2 years residency in Japan and USA. So we have lots of the cerebrovascular surgeries, green in Japan, so we have more cerebrovascular surgeries. But brain tumors, half, and the spine are lots of the cases in the USA. That's really influenced me of my practice. But anyways, so number of the cases, okay, 3 times more than Japanese training systems. So they do more surgeries, much more than the Japanese neurosurgeons. So when they graduated from the residency, remember 7 years, they have done 2,000 operations experience. Maybe, it's more than 3 times than the Japanese regular residency. But the question is, surgical skills of US neurosurgeons, they do 3 times more surgeries, okay? Do they 3 times better than us? So that's the questions. Of course, you think about the sports, or you think about the music instruments. Like you practice more, you can be better. But it's a little bit, unwanted things. US neurosurgeons is 3 times better than the Japanese neurosurgeons. So actually, my answer is no. Okay, are they 3 times better? I don't think so. So why is that? So this is the surgical records. This is the first year when I wrote my surgical records. Okay, this is a clipping. So I just the illustration is not so great, but I say, okay, this is the skin incisions, open. Then I put all the tips here. So if I look back, I can think about what I have thought about it. Then, we have time, at least we are required to write those things when I was in training. But how about the medical records in USA? It's like this. So this is done by staff members. Their responsibility, that they have actually the dictation systems. So after the surgeries, they speak over the phone about the surgical records. Then at night, somebody wrote it. Then it's been updated in a chart. So residents actually don't really remember any cases because after Monday, you have another case on Tuesdays. So there's not much that we can review or we can prepare for each case. So in Japan, good things. We have been trying to learn more from one case. Then of course, we have lots of way that we can practice. We don't need to go to the surgery, but we have other method that we can practice surgeries. So this is a chicken wing that you can buy chicken wings tomorrow and see it. There is a good vessels that we can use for the anastomosis practice. So you don't need, you just need a fine instrument, but you can practice anywhere. So of course, as we know, surgical skills, the competence of surgeons cannot be measured solely by surgical skills. So good surgeons, what is good surgeons? Good surgeons, it may have, of course, should have a good skills, but something more than that. So not only the surgical skills. This is what the good surgeons for. So difference between US and Japan. This is the last things. So maybe I sometimes ask you about the question to the medical students to the 5th grades, saying that which department or subspecialty do you want to enter or do you want to go after you graduated from medical schools? So I have asked all of the students because I always ask in the first day of the neurosurgery rotations. Somebody say, okay, I want to go to the pediatric. Somebody say, I want to go to urology. But most of them is, well, something surgical things, something internal medicines, or some people like haven't decided yet. Most of them haven't decided yet at the 5th grade. But that's usual things, okay? Because you have 5th year, 6th year, then there's a 2 years internship. So you have 3 more years that you can think about, then decide. Then you can decide it 3 years later, then which is okay. But in USA, if I ask the same questions to the students, everybody answers, I want to be a neurosurgeon, I want to be an orthopedic surgeon, I want to be a general surgeon, then they are really always a competition among the medical students. So to get into the medical residency, they have to focus more in area. Otherwise, let's say they want to be a surgeon in a 6th grade, they cannot. Some students want to be a surgeons, neurosurgeons, for example. They have started writing the papers in the 5th grade. Then say, this is a paper that I helped. Then I'm really interested in neurosurgery. That's what they say in an interview. So every medical students who I saw in USA, they have already decided what they want to be, at least in the 5th grade or even younger. That's really different in Japan and USA. But that's a system. But don't worry, it's good things that you can have a freedom. You don't need to decide now. Because I decided to be a neurosurgeon when I was in the 7th grade. After I come back from the USA, then I wanted to, what I want to be, I haven't decided, then I say I want to be a neurosurgeon. So if I decided to be a cardiologist at the 5th year, I mean, I am not here. So it's good things. So just make best use of your opportunities. But remember, people decide first and focus on neurosurgeons. So neurosurgery residents, they are really, really neurosurgery residents from the start, because they have been thinking about to be a neurosurgeons for 3 years, then got into residency. So they are really, really motivated. That's a difference. So in the last, I'm passing a little bit time, but for the future. So this is really good picture. I like it. I see some of the people here, and really like this. So that's why I want to have a collaboration with Indonesia, not only Indonesia, but other countries. We are the TMPU in Tohoku District, Sendai. We have been motivated to help Tohoku District. Yes, it's important. But of course, we have to see the future in the world. So touch upon a little bit about the Indonesian-Japan connections. So how many neurosurgeons in Japan and Indonesia? As Professor Fadi touched upon. So, populations. Remember, Indonesian populations, 2.5 times more than Japan. Okay? Then you said 600, but I just wrote 500. So in Japan, let's say 10,000 neurosurgeons already registered. So 500 neurosurgeons. So how much populations per 1 neurosurgeons? Of course, this is calculations. 1 neurosurgeons, Dr. Irwan taking care of 40 times more patients than I do. So which is busy and more responsibility, a more difficult job, I guess. So neurosurgeons in Indonesia should have more surgical opportunities, which is great things. To be trained, to get better, you want to do practice more. I said surgical skills is not only the things, but at least you have a surgical opportunities. So what is going to happen? This is the pyramid of the populations. Have you seen this Japanese population chart? And look at the Indonesian chart. This is very different, that the younger generation of Indonesia is evolving. Then, as we know, Japan is really, really higher ages, elderly people. So it's very scary to see what happened to Japan, populations. So now we are in 2025, but it's going to be 90 million 9,000万人 in 2050. Now we have 120 million, 1億2000万, but we lose a lot, 30 million in 25 years. So how about Indonesia? They are getting more, 2050, so they reach to this 300 million. So they are going to have more populations. So neurosurgeon in Japan is, I'm afraid, that we are going to have less surgical experience. We are thinking we are busy, but we are going to lose surgical experiences. So my role as a professor here, I would like to motivate younger generations to have more surgical experiences. So I would like to let the young doctors do the surgeries, then they enjoy and learn, because we can learn from what he did. So I remember when I experienced younger days residency program, even in Japan, I had operated a lot. Lots of the hematoma, trauma, which we don't have it because we have automatic driving, no big accidents, which is good things. So, but look at the Japanese pyramid, 1975. Similar to Indonesia now. So maybe we can go back to the past if we go to Indonesia. That's why I use the same pictures. Have a collaborations. You mentioned that you send your residents here, which we really appreciate, hardworking, and learn a lot and good help for us. Really appreciate Farhan, Irwan, Samuel, Brahma, Maneho, please come next year. So, but from my perspective, I want to send neurosurgical residents to Indonesia. So, Kyohei, spend 1 month in Indonesia, then you can do 5 trauma cases every day. Then you can be a master. If you spend 1 month in Irwan's home, you can be a master. You can have lots of experience. So that's what I'm thinking. So we can probably help you a win-win situation, which we call. So that's what the future goes. Terima kasih. Thank you very much. So we can have some comments. There's going to be a mic. Please. In English, please.
Yes. Question? I have 2 questions. First one is, when and how did you decide to get a medical license in the USA? That is the first question. The second question is, how were you able to start your surgery at Mayo Clinic? Did you win the competition? I'd like to see the situation. Okay.
So the first question is, how did I, what? Can you say it again?
When and how did you decide to get a medical license in the United States?
So that's when I had experience in the University California and exchange studentship. I went to exchange studentship. Then I have free time. Then I played soccer with a Brazilian and a Mexican, and I play golf. Then I had nothing to do else. Then I was thinking, okay, what should I make best use of this time? Then I have thought about, okay, let's think about seriously to take the US medical license examinations. Then I thought, if I did it, my year in California is going to be much more meaningful. So that's how I decided. Of course, I'm interested in the United States. I have studied English by myself, and but I really motivated after I went to the USA. Then the second questions, I got the positions, which is really lucky, because this is the just a coincidence. But I got the positions in the Mayo Clinic, which is not the real residency, but this is the 2 years limited falling exchange fellowship program. But I serve as the same as the senior residents. So I was assigned to the chief resident service. Then, you know, after I got accepted to the fellowship, I was same as the other residents. So I was always asked to do the first assistance of all the cases. Then later, I can take care of other cases by myself. Sometimes that's the small one. But 2 years, work as senior residents. I hope I answered your questions.
Thank you.
Thank you very much, Professor. So my question is how you will answer the question from your student, how to balance between your clinical activity and your academical achievement. Why you should balance that? Because these days everyone just want to become neurosurgeon. A lot of operation, difficult cases. And in my country, most of the young neurosurgeon, they forgot how to tell everyone about their case, the pitfall, how they branding themselves with many cases, for example, because we have many cases. So how you tell your student about that?
You mean the clinical work and academic? Academic is the basic research? Not necessary.
Not necessary.
Okay. But the maybe I have to put it that way. You know, we are neurosurgeons, okay? Then you folks wants to be good surgeons, okay? Then let's say we want to do the bypass very well, so we practice using the chicken wings. So that's really a difficult task. So this is clinical, okay? So people wants to be a good neurosurgeons. So this is really, really clinical things, okay? Difficult clipping, difficult bypass, difficult tumor surgeries, but that's everything is already established by the other people. So even though this is a difficult case, you know, we do clipping, we do things, but this is really the, you know, just following the other people's path, okay? But let's say we have experienced an interesting case. Then as you do regenerative medicine, you know, so the research, even clinical or basic. So this is the, let's say, something new, creative. So you have experienced the good cases, then you present by writing the papers, which is you say, okay, listen, this is what I learned. This is what I found. This is new things. So this is what the academic part works. So this is sort of the, I would say, exciting things, you know. To do the surgeries, difficult surgeries, is very exciting things. But writing a paper, for example, or having the new method or creativity, which is very exciting academically. So that's what we look for it. So yeah, maybe students, young neurosurgeons, there are two ways. One is go to clinics, clinicians, do the surgeries, see patients every day. Other is academic neurosurgeons. So maybe we are kind of in positions, motivate young peoples to the academics. But I think academic work, writing a paper, inventing something, new method, is it even clinical research, basic? They are really important, I think.
Thank you very much, Professor.
Maybe we are going to take pictures, so you guys start to gathering in the middle, please.
Sensei,
Yeah?
yes, thank you for your presentation, good presentation, and thank you to Sendai University. I really enjoy my stay in this university. So my question is, being a neurosurgery resident is really stressful and really have tight schedule, and you have so many schedule. You have to wake up at 4 a.m. and finish at 9 p.m. and after that you have to prepare the surgery, and many of uh, people of young neurosurgeon resident maybe they want to give up, maybe because of the stressful schedule and tight schedule. So what can you give for us the young neurosurgery resident for their motivation to they don't have to they have the spirit to finish the residency, and they have to they can manage the time for study and for the patient also, and what can give motivation for the young neurosurgery resident. And the second question is, I'm as the young neurosurgeon, you said that the skill is not always the first for the neurosurgeon. There is others. So what can you give advice as me as the young neurosurgeon to be good at neurosurgery?
So your question is, of course, about the residency program. Okay, the people have to wake up at 4 a.m.
Yeah,
Then it's a hard job.
yeah, I have job and
So I mean, but they know that they are going to be like that. So they are really prepared to it, I think. Then they have been trying to get hard enough to get the residency positions.
yeah.
So I don't think they would really complain about it because they knew it. But I guess there's not much time in Kokubuncho time, okay? So
Yes.
Mayo Clinic actually is a really good place
Yeah,
because there's nothing fun
yeah,
in town.
yeah.
There's Minneapolis, which
Minneapolis.
is a good big cities.
Mhm,
This is where the Japanese restaurant was.
mhm.
It takes 2 hours to drive. So all the time, weekend, sometimes I'm on call, sometimes I'm not. Then on the weekend that day, I wanted to go to the sushi restaurant in Minneapolis. That's the enjoyable fun. only fun that I had in a month.
I see.
So it's hard, but I mean, after the hard pass, they can be a neurosurgeons like you. So this is the motivations, I think. Okay. So that's how they keep up their kind of motivations. Then for you to be a good neurosurgeon, I think you have to, train yourself. But I think you have been doing a good job because to see other people's doing the surgeries, not only see your hospitals, but you have to see the other place, other way of doing. Then you can collect whatever the good things to you. Then you have built up your 801 way. Okay.
Thank you so much.
Thank you for your great presentation. And what do you think is important when giving an English presentation, like especially in international situation like this?
English presentation?
Yeah.
First thing is, it's not necessary to the English, okay? Even the Japanese presentations. You have seen the presenters who is reading some notes, then they don't see nothing at all. But look at Professor Farid. He's like coming here to the audience. So that's what's really important for the presentations. So then maybe you guys have a lot of chance to do the presentation in Japanese and English, but try to find one person, then look his eye or her eye, then keep seeing it. Then you can see, I can see that, Kantaro may be feeling sleepy or some Kyohei may be sleepy. I can see it. I have been paying attention. Then that's how I controlled my talk. Then English, I think the best way to study English is you hear English, then you repeat. So there's a lot of AI, English, teaching materials, interesting modules. But what I recommend is you hear English, then you speak, even without any understanding. Okay?
Without understanding?
Yeah, maybe you can ask Ryuji about how to speak English. I'm joking. But anyways, so without understanding, you don't need to understand. You have to hear the sound and speak. Maybe you can try in Japanese. You can hear the news and you can speak, which you can do it. So basically, you can do the same thing without understanding. You don't need to understand. You can just imitate the sound. Okay? I have been in USA first time when I was 25. So I spent 1 year in University of California, then just hang out, just try to pretend their pronunciations. So just try to be imitating. Then I think you'll be good enough to communicate, okay?
Okay, thank you.
Thank you for the lecture today. I have, actually, it's not kind of a question, it's kind of a suggestion. But you said that, we should do something kind of exchange program with the residency, but I want an exchange program for the student, medical school student, because this university is, is kind of not that there's no kind of history. So there's literally nothing to do with exchange program, like studying abroad. And it's okay to, study like only for 2 weeks or only 1 week. But I think, it's important to have some opportunities to learn abroad. So, 遠藤先生、よかったら 新しいこ
新しいのに
う交換留学プログラムを change program.
Uh,
Yeah.
Yeah, I mean,
That
I
would
agree
be-
with you. We are new universities, okay? So we have not prepared for the exchanging programs or anything. But, you know, maybe there's a lot of public opportunities for the make abroad. So, you know, each student's trying to find a way so they can apply to it. But what I used is the Talk University Exchange Program. So yeah, you're true that we are universities that we have to make exchanging programs. Okay, so maybe can we send the students to Indonesia next year? Okay, so that's how it works. But the Farhan is here, been here for 6 months. So he goes back, then I'm thinking I don't think it's really possible, but like you guys rotating 1 month to neurosurgery, like you did in the 5th grade. So using that 4 weeks, we may think about sending students, even though 4 weeks, to Indonesia. But you have to afford plane tickets by yourself. But that's what I'm thinking. Yeah. But so your point is really good, and that's what I have been thinking. Then I also, you have figured that we have had a connections with Korea, South Korea, which is more closer. There is a direct flight from Sendai to Seoul. Then I have Korean universities to work with. So, but your point is really appreciated. Thank you.
Thank you so much.
Okay? Yes?
Thank you very much, Professor Endo, for the great, inspiring presentation. I have 2 questions. My first question is regarding your statement. I was really interested when you said that more surgery doesn't mean you become expert. You can become better at surgery. More training, more surgery doesn't mean you are an expert. I would like to ask your advice, especially for my fellow Indonesian neurosurgery resident. Now we have more and more residents, so our experience is different between 10 years ago, few residents, so every resident have more cases to learn. But now, even more and more residents came, and that means less surgery for every resident. I would really like your advice how to reach that kind of expertise, even without that many cases, just with a few cases. But I observe it myself in Indonesia that we perform a lot of surgeries, but we rarely reach that kind of
Okay,
expertise.
let me answer your first questions. So this is my idea, okay?
Yeah.
So right now we have residents from Southern Tohoku. This is Dr. Aono. So how we can train him, okay? It's easy, I mean, to let him do and learn from it. But, not all of them have the cases. That's your point, right? So, to observe the surgeries, okay, just see it versus think and see, okay? That's way different. So you would advise your young residents, okay, you are in the operation room, so you see my surgeries, but think about doing the surgery tomorrow by yourself, okay? Then people start to think about how to cut. We cut the skin. Then if you want to do it, we have to know how deep we go. We go to the bone or we go to the muscles. So we have to know. Otherwise, we cannot do. Also, one thing is you have to ask your residents to write a surgical report before surgery. before. So we do the surgeries, okay? You write a surgical reports after the surgeries. No. You write before surgeries. Then you can tell how much they understand, how much they prepared. So even a simple case, you have to ask your residents to provide surgical report, presumed surgical report 1 day before. So if you think it's good enough, let them do. Then they will probably, learn more. Learning speed is higher, I think.
Thank you. Thank you very much. And my second question is about, I want to hear your opinion about the recent neurosurgery resident system in Japan. What do you think can be improved with now condition? It might be different than before with that so many neurosurgeons already established in Japan. How can you improve the system that we might face the same problem in the future? Thank you.
Yeah, thank you. Good point. And then I think the part of the answer is spine. So we call brain surgeons in Japan, Nogeka. This is brain surgeons. But we should be neurosurgeons, which is no shinkei geka. Okay? So the people think no brain surgery, no, the general people think Nogeka only do the brain surgeries. Even students, they don't know the neurosurgeons have spine cases, which is as important. So, this is really the issue for Japan and all over the country, like aneurysms, which Professor Sasaki asked, how much population's percentage for the clipping versus coiling? Then I bet there is going to be 95% is going to be coiling soon. So there's no case for the clipping. So we cannot train the people in clipping. So we do endovascular, but me, I didn't want to be an endovascular when I was a student. So maybe I should, motivate people to more involved in spine. As we know, the spine cases is, neurosurgery, decompression of the nerve root, make the patient happy. Outside the brain, doesn't matter, this is neurosurgery. So I have to think Japanese neurosurgeons have to do more spine cases. Don't leave it to the orthopedic cases. I have orthopedic surgeons in a very good relationship, but I think neurosurgeons should do more in spine. Then we can make best use of microsurgical techniques. So that's part of my answer. Okay?
Thank you very much.
Okay, I think that's it. Then there's no questions through the website. So thank you very much for coming, and big applause to the Professor Farid and to all. So again, please come to the front. Maybe Professor Farid, you sit down in the front. So everybody please come to the 佐々木さん一番前に来てね。So thank you very much, and we gather in here. So please try to sit down here, please. Then we move to the cafeteria soon. So just 4 or 5, please. Going. 座って。So thank you very much. We are going to finish the Zoom meeting. Thank you very much for joining, and really appreciate it. Then actually now you can see the many people are gathering now. Then thank you very much for your time. Then I'm going to quit the Zoom now. Thank you very much.